So myself, sir.
Ah,
My topic is opioid, sir, pharmacology and uses.
right. Pharmacology. Okay.
Opioid is derived from Papaya somniferum, a poppy plant. Opiate is a natural. Opioid is derived. Any chemical has activity on opioid receptor, which includes endogenous opioid, natural opioid, and synthetic opioid. Classification based on source and chemical structure. Natural opioid includes phenanthrene derivative and benzyl isoquinoline derivative. Phenanthrene derivative includes morphine, codeine, and thebane. Benzyl isoquinoline derivative include noscapine and papaverine. Semisynthetic. In semisynthetic, the morphine derivative include heroin and dihydromorphone. Codeine analogs like tramadol and trapentol. Thebane derivatives like buprenorphine and etorphine. Antagonists like naloxone and naltrexone. Synthetic opioids, phenylpiperidine derivatives, pethidine, fentanyl, and remifentanil. Morphinone derivative, levofenol and butorphanol. Benzomorphone derivative includes pentazocine and phenozazine. Phenyl propylamine derivative, methadone and propoxyline. Opioid receptors. Opioid receptors are G protein coupled receptors present in the cell membrane. They are rhodopsin family, 7 transmembrane spanning proteins. When opioids bind to receptors, it stimulates the G protein coupled receptor intracellularly and inhibits the voltage-gated calcium channels in the presynaptic membrane, which inhibits the calcium entry and which subsequently inhibits the neurotransmitter release. Other mechanism includes it opens a potassium channel in postsynaptic membranes, which hyperpolarizes the membrane. It also inhibits adenine cyclase, which leads to decreased cyclical AMP, and also stimulate MAP cascade, which leads to tolerance. On pain stimulus, neurotransmitters are secreted. Normally, neurotransmitters include glutamate, substance P, and CGRP. Glutamate, which stimulates NMDA and AMPA receptors, and which increases the cation conductance and causes a pain. Substance P also stimulates neurokine 1 receptors. CGRP also produce ion conductance. This opioid receptor activation presynaptically inhibits the calcium conductance and inhibits the glutamate and substance P secretions. Postsynaptically, opening of potassium channels, which hyperpolarizes and decreases the activity of NMDA and AMPA receptors, which modulates the pain. There are 3 types of receptors: mu, kappa, and delta receptors. Mu1, mu2, kappa, and delta. The effects include mu1 receptors effect include analgesia, spinally and supraspinally, euphoria, meiosis, low abuse potential, and urinary retention, bradycardia, and hypothermia. Mu2 receptors analgesia through spinal and depression of ventilation, constipation, which is usually marked in mu2 receptors, and physical dependence. Kappa. Analgesia is both supraspinal and spinally, dysphoria and sedation, meiosis, low abuse potentials, diuresis, respiratory depressions, and that's it. Delta. It also produces analgesia, depression of ventilation, constipation minimally, and physical dependence and urinary retentions. This classification based on binding to receptors, pure agonist, both mu and kappa receptor stimulations. It binds to both receptors. The drugs include morphine, pethidine, fentanyl and its derivative, tramadol, codeine, and methadone. Partial agonist, it binds only to mu but not to kappa. It includes buprenorphine. Agonist and antagonist, which only binds to kappa, most commonly nalbuphine, butorphanol, and pentazocine. Antagonist, which does not bind to both mu and kappa, naloxone or naltrexone, nalmefene, naloxone, which are peripherally acting opioid antagonist. Now coming to pharmacodynamics. Analgesia function is mostly modulation of conduction and modification of perception. It occurs at 3 levels: peripheral opioid receptors, spinal in substantia gelatinosa, which includes kappa receptors, and supraspinally periacutal gray matter. Supraspinally, the pain is transmitted through spinothalamic tract and ascending spinal mesencephalic tract, which stimulates a periacutal gray matter in the midbrain, which eventually stimulates rostroventral medulla, the raphe magnus, and descends to the spinal cord and secrete enkephalins, which modulates pain pre and post synaptically. This measure of analgesia has a max sparing effect, usually tachycardia, sweating, and respiratory rate. The objective measure of analgesia is analgesia nociceptive index, the range of analgesia will be 50 to 70. It is usually based on heart rate variability. Second, sedation. Sedation is a reduced acetylcholine output from the prefrontal cortex and basal forebrain. Euphoria. Opioid act pre and postsynaptically and decreases the dopamine, which occurs at nucleus accumbens, which leads to euphoria. Pruritus. Pruritus usually mediated by histamine release, which due to morphine and stimulation of trigeminal nucleus and peripheral opioid receptor activations. Treatment is usually opioid agonist or antagonist, emetic or peripherally acting antagonist. Muscle rigidity is usually due to stimulation of mu receptors in the striatum. It causes increased dopamine and decreased GABA, results in woody chest, adducted vocal cord, and lead pipe trunk. It's mostly common in fentanyl, which leads difficulty in ventilation. So we should be alert in patient with Parkinson's. It can be avoided by pre-treatment with benzodiazepine, low-dose muscle relaxants, or propofol. Meiosis is usually mediated through Edinger-Westphal nucleus in the midbrain. The afferent from a light like a pretractal nucleus comes to Edinger-Westphal nucleus, and parasympathetic, which results in pupillary constriction. In case of opioids inhibits the inhibitory neurons and causing meiosis. The inhibitory neurons act on Edinger-Westphal nucleus. It is usually measured by pupillometer. Then respiratory system, all inputs from respiratory systems are inhibited. The rate and depth are reduced, usually from pons, pre-Bonsinger complex, and cortical region. Reduced response to carbon dioxide and hypoxia. It has antitussive effect, most commonly with remifentanil. Next CNS effects, it reduces the cerebral metabolic rate of oxygen and cerebral blood flow. In case of intracranial tension, it has no effect. This neuroprotection is mediated to delta and kappa activations. CVS effects, it has no effect on contractility. There will be bradycardia due to direct depressant action on SE node, which decreases the heart rate. No effect on coronary circulation. Antiarrhythmic effect is there, except pethidine, which causes tachycardia. GIT, the most commonly nausea and vomiting due to stimulation of delta receptors in the CTZ zone. The transmission involves complex dopaminergic, cholinergic, serotonergic pathway. It is also aggravated by movement. The more dose, which inhibits the vomiting center, but less dose stimulates the CTS. So pre-op prophylactic antiemetic should be given. Biliary spasm. This contraction of sphincter ODA causes biliary colic. Contraindication of morphine in acute pancreatitis. It is fully reversed by naloxone. Genitourinary cause urinary retention due to detrusor next, opioid-induced bowel dysfunction, the constipation. Due to mu receptors in the enteric nervous system, which inhibits the bowel movement. It is usually treated by peripheral opioid antagonist like naloxone, albumorphin. Opioid in obstetrics, it is a non-teratogenic, can be given for oocyte retrieval, causes hypotension due to iodocaval compressions, but transfer to fetus increases, which cause fetal acidosis. Role in fetal surgery, neonatal abstinence syndrome in opioid-dependent mothers. Other effects include thermoregulatory threshold, decreased thermoregulatory threshold, cutaneous vasodilation, physical dependence if used more than 25 days, and tolerance to accept constipation and meiosis. Next, coming to pharmacokinetics. On administration of IV, it goes to central compartment plasma, then eventually moves to move to rapidly equilibrating compartment and effect site. Later, it goes to slowly equilibrating compartment. Onset, effect site concentration depends on plasma concentration, plasma protein binding, and lipid solubility and ionized fraction. Ability to cross blood-brain barrier also depend on lipid solubility, ionization, molecular size, and protein bind. General principles, all opioids are weak bases. Normally, they dissociate into base form and protonated form, and like morphine, and sulfate. Unionized and non-protein bond form penetrate the biophase and produce the onset of actions. The principles like pK of morphine is 8 and unionized fraction at pH of 7.4 is 23. Lipid solubility is 1.4 and plasma protein bond is 20 to 40. So maximum diffusion occurs. Morphine is mostly water soluble drug. Fentanyl, remifentanil, sufentanil, alifentanil, lipid soluble drugs. Normally opioids get distributed in the well-perfused tissue, undergo gluconization liver and excreted via kidney. Hepatic metabolism, mainly phenylpiperin derivatives. And others like heroin and all metabolized by tissue esterases. Next, antagonist, naloxone, naltrexone and nalmefene. It is usually opioid antagonist like oxymorphone derivative. Naloxone is most through IV route. Naltrexone and nalmefene is given orally. Naloxone competitive antagonist of all three receptor but greater affinity to mu. It is a lipophilic and crosses the blood-brain barrier. Onset is usually 1 to 2 minutes and T-half of 1 hour. It is metabolized by liver and excreted in urine. Normal dose is 0.4 to 0.8 mg IV over 10 minutes, but can be repeated every 30 minutes. In a neonate, we can give up to 0.1 to 0.1 mg per kg. Side effects, it causes immediate breakthrough pain, tachycardia, hypertension. As the risk of re-narcotization with opioid due to the clearance rate is high, so effects last only for 1 hour. So repeated dose should be given. Naltrexone, it is given orally, but it has a long-acting T-half of 8 to 12 hours. Dose of 5 to 10 mg. Nalmefene, it is also given orally. It has a long T-half of 3 to 10 hours. It is usually given in alcohol dependence case, but it has a protection to delayed respiratory depression. Neuraxyl opioids. The placement of opioid in epidural and intrathecal space, the opioid receptors are present in substantia gelatinosa. This epidural, in case of epidural space, drugs absorbed through fat, venous plexus, and other things. And diffuse drugs can also diffuse and absorbed in CSF, through which it can be bind to opioid receptors. Epidural opioid only produce analgesia with no effect on motor function, autonomic function, and proprioceptions. It usually depends on fat solubility and molecular weight. Intrathecal epidural, more lipid solubles like fentanyl and sufentanil diffuses into spinal cord and bind to dorsal horn receptors. So it causes rapid onset and minimal cephalid spread, short duration. So decreased risk of delayed respiratory depression. Less lipid soluble drugs like morphine, slow to bind to dorsal horn of spinal cord opioid receptors. So slow onset, prolonged duration of action, more cephalid spread. So increased risk of delayed respiratory depression. Complications of neuraxyl opioids, usually dose dependent, most commonly pruritus, nausea, vomiting due to interaction and activation of CTS in fourth ventricle. And urinary retention is most commonly in epidural opioid. It is not dose dependent, is due to interaction with sacral opioid receptors. Parasympathetic outflows decrease, the tetrazoa muscle relaxes and cause urinary retention. And respiratory depression, which may occur in within 2 hours, or late onset with after 6 to 12 hours in case of morphine. That's it, sir.
Okay. Uses. They are not mentioned uses. Part of that question, isn't it? Where do you use it?
Sir?
The question is pharmacology of opioids and its uses, isn't it?
Yes, sir.
Where do you use it? Is it for acute pain or chronic pain or labor pain? What are all the indications for its use?
Chronic pain, acute pain, and labor analgesia, elective emergency LSCS.
So that also you have to mention. Okay? That only completes the answer.
Okay.
So you have prepared the answer more just like a third year pharmacology question answer. Okay. From anesthesia point of view, you have to include some more recent advances in opioid pharmacology. So first of all, nowadays we don't say mu, kappa, delta receptors. We call them as MOP, COP, and DOP. Why we call them like that? MOP, KOP, and DOP. What does that mean?
Mu receptor.
Mu
Mu
opioid, kappa
kappa.
opioid, and delta opioid. So nowadays the whole description, so pharmacology of morphine or opioid description is termed as MOP, KOP, and DOP. And earlier description, I agree, it was mu, kappa, delta receptors. We were talking about the receptors. But now with the peptides, ligands which are there, which are binding to these receptors, the actions are being done. And you have exogenous opioids and opiates, and you have endogenous opioids. You have not talked anything about the ligands which have their endogenous effect on that. What is the purpose of that? What is enkephalin? What is endorphin? And how do they help in your pain threshold and tolerance? That is also one of the another point that you have to include. And the most recent advance in opioid pharmacology is NOP. Have you heard of NOP? Just like MOP, KOP, and DOP, we have NOP, nociceptive opioids.
Yes, sir.
And they are also included as part of the opioid receptors. Okay? And even though they are not called as a classical opioid receptor, because the one criteria to say that a drug or a ligand is opioid receptor or a opioid peptide. What is the one important criteria to define them as a opioid drug?
Derived from poppy plant.
Oh, see, poppy plant is the naturally occurring drug. Nowadays we have so many semi-synthetic and synthetic drugs are also there. When you want to call a drug as opioid, the initial criteria to define a drug as a opioid or a drug of a property with a opiate.
Pain relief.
This is the important criteria that was stipulated. That drug effect should be reversed by naloxone. Then only it can be called as a opioid or a opiate. That was the stipulation that was given to define a drug as a opioid group of drug. But this NOP is not reversed by naloxone. But still the current trend or the recent advance is NOP is also included among the opioid receptors as the fourth opioid receptor. Okay, MOP, KOP, DOP, and NOP is the fourth receptor which has been found because it is involving and it has also got some effects on the opioid receptors to produce some analgesia and also sometimes counter the effect of that, and so it is also included, and a lot of newer advances have come into interest is being shown in the nociceptive receptor NOP. Have you heard of the term biased agonism? You talked about agonist, partial agonist, and antagonist. That is also one of the classifications of the opioid activity. You can classify opioids into various categories. One first category is they can be synthetic, they can be semi-synthetic, or they can be naturally occurring. And the second classification is the drugs can be a total agonist, they can be partial agonist, they can be antagonist, or they can be inverse agonist. This is the second based on the mode of action and affinity to the receptor. And now they have introduced a newer term called biased agonism. Have you heard about that?
No, sir.
Supriya, Soundarya,
No,
you have
sir.
read about that?
No,
So
sir.
this is a very recent thing that has come into that. So I thought I will keep you aware of that also. So my presentation will not be on the regular basis of the pharmacological description what you have done as a correct pharmacology question answer. You talk about the chemical nature of the drug, then you say how is the mechanism of action, then you talk about the pharmacodynamics and the kinetics, and then elimination, the routes of administration. All these things are the classical ways of answering a pharmacology question. But this presentation is mainly made to give you an input on the recent advances Is there a role for this opioid receptors on sepsis? Do they have a role in sepsis? Management of sepsis? I think we'll have to just go through and see how it is. I'll share my screen with you.